We are very, very privileged to have two excellent speakers, physicians this evening on weight management. Dr. Theresa Schwab is right next to me, and she's an obesity medicine and emergency medicine internist and has over 31 years of experience in the medical field. I looked at that and said, no way. She does not look like she's had 31 years. So whatever you're doing, keep it doing. Dr. Schwab completed her medical degree and residency at the University of California, San Francisco. Maybe that's it. California? She did a fellowship at the School of Medicine, McMaster University in Canada. She is a diplomat of the American Board of Obesity Medicine. Dr. Schwab is certified in primary care psychiatry and is board certified in emergency medicine. And we all know that weight management has a lot to do with behavior and what's going on up here. So that's a very important thing to have in combination with all of this. She has spent the last 10 years studying, God bless you, fitness and nutrition, learning the impact of our daily lifestyle on our bodies. She understands the science regarding weight and the myriad changes that occurred due to the increase of overweight and obesity. She uses evidence-based clinical practices to guide her patients' weight loss journey to improve their health, wellness, and longevity, understanding that many factors contribute to weight and that each patient will require an individualized, unique approach to weight loss. She is affiliated with Advocate Christ Medical Center, and she has offices in Oak Lawn and Burr Ridge. And Dr. Tikwani, right next door, is she received her medical degree or her education at Rush Medical Center, her residency at Christ Medical Center. She's board certified in emergency medicine and obesity medicine. She also has primary care psychiatry. Her hospital affiliation is Advocate Christ Medical Center, and she is also have offices in Oak Lawn and Burr Ridge. So thank you very much. Thank you. They will also be speaking in Lamont if you want to see it again, or tell someone else to see it at the Lamont Library in November.
Thank you so much for that. Impressive. No, that's a lot of time, a lot of years. Good evening. I am Theresa Schwab. I am very happy to be talking to you tonight about our passion, which is obesity medicine. I'm sharing this lecture with Dr. Theresa Schwab, my partner. We would like to take this opportunity to thank Advocate Health as well as the Oak Lawn Library System for giving us the opportunity to discuss what we believe are really important topics. And of course, as everyone knows, and I'm a fast talker, so I apologize beforehand, but you can always ask me to slow down. Or if you have a question, we're going to try and get our lecture done relatively quickly, so that we can have a question and answer period after. That being said, this topic is really in the news in the last few years. We all know this, and the major reason behind that is because of the usage and of two new medications that have hit the market in the last few years, very famous, very successful, very good medications, semaglutide and tirzepatide. So that is really what's driven a lot of people to thinking about medical weight management. So let's dive right in. I wanted to start by saying we have no financial disclosures. And then I wanted to talk about something we pretty much are all aware of, and that is that this is a very common problem. This is just a simple graph showing the rates of obesity and overweight as defined by weight over a 20-year period. And what you can see is in that 20-year period from around 2000 to 2020, there's been a 37% increase in the disease in adults and almost a doubling in children. And it's really a very substantial problem. It accounts for over $170 billion in medical costs. And what's more startling and more frightening really is that we're seeing diseases in our children that are unheard of. And what I'm specifically referring to is metabolic dysfunction associated liver disease. That is also previously known as fatty liver disease. So in the past, liver failure was typically seen in the disease of alcoholism. People would drink, their livers would get inflamed, that inflammation would lead to scarring, which is known as cirrhosis, and then a certain percentage of them would have fulminant liver failure. Now, the number one cause of liver failure in the United States is from obesity and overweight. And we're seeing this liver disease in 25% of our children. So it's a huge problem, right? You can't understate it. So the first thing I like to do, and I think the most important thing I can do, besides getting more into the science, is to really talk about myths and facts. As we all know, everybody has an opinion about weight and food and nutrition and exercise. We are replete with people's ideas, and quite frankly, much of the popular talk that we're reading about is wrong. And so I am happy to take a few minutes to talk about myths, right? Definition up there, a popular or widely held belief that is in fact false, versus fact. So I'm going to start with the idea that people say obesity is not a disease, it's a risk factor, it's a lifestyle problem. And that is untrue. So what is a disease? What is a chronic disease? I've listed the causes. I don't want to spend too much time reading the slides, but a chronic disease is a disease that affects an organ or a system of organs that causes those organs or even the entire body to malfunction over time. It has stages. It leads to further organ dysfunction. It causes other diseases and is manifested by signs and symptoms. And of course, I'm bringing this up because obesity does all of these things. It causes disease in organ systems. It causes diseases in the body. And I've just named a few. This slide could be 10 slides. So it does several things, which I'm not going to read. It has stages that leads to end organ dysfunction. We talk about the stages of obesity when we're discussing it amongst our medical professionals. It causes 236 obesity-associated conditions, including 13 cancers. Most people don't realize that obesity causes cancer. It definitely does. And it is manifested by signs and symptoms that we're all sort of familiar with: joint pain, chronic inflammation, lipid problems, elevated blood pressure, exercise intolerance, problems breathing problems, sleeping. So obesity, in fact, is a chronic disease. It's been accepted by almost every medical society in the US and Europe. There really is no one who doesn't believe it's a disease. And this is the actual long-winded definition of obesity that's been defined by the Obesity Medicine Association. It says 2023, but this definition goes back to 1998. It's been modified over time, but you can go ahead and read it. The key point, right? It's very scary to talk about all those things. That I should probably highlight is that this is a treatable disease, okay? So let's go to the thing that probably bothers us the most, and this is this next slide. Have you ever heard it's a willpower thing? This is all about willpower. So you're overeating and you're not moving. Okay, this is the biggest myth in obesity and obesity medicine, because it completely disregards the science, and that's what the next part of this lecture is going to be about. And I've just picked a few things from the popular media that people say, generally in positions of government, about weight. And you'll see it's a lifestyle, it's about decisions, it's my fault, it's personal responsibility, it's choice, right? You need to eat less and move more. If you've had a doctor tell you that, then they're not actually up on the science either. So we know the myth. So what is obesity? I've talked about it being a chronic disease. What it really is a neuroendocrine disorder. And I'm going to define those terms in a minute. But basically, our bodies are supposed to be in balance. We have expenditure and we have intake. This energy balance, if it's working properly, means that we have a neutral weight. Now, that weight can be affected on that little fulcrum there of the seesaw you're seeing by inherited and environmental factors. That's really the crux of it, right? There's also, when I say environmental, I can talk about our food supply, and if we have time, I'll do that after in the question and answer period. But that's one of the biggest environmental factors is our food supply is, in fact, incredibly toxic now. But as I'm mentioning, it's a neuroendocrine disorder. So what is that? Neuro is the brain. Endocrine organs are organs that secrete substances that we call hormones that affect in other parts of the body. So examples of endocrine organs that are involved in our energy balance are listed there. Our brain, our gut, our pancreas, our thyroid, our adrenals, our actual adipose tissue, that's our fat tissue, our sex organs. All of those are examples of hormone secreting organs that have a significant part in our energy regulation. And the coordination of these organs is really a very specific and very complicated process, right? I absolutely love this quote by George Bray, who's a pretty prominent researcher in diabetes and obesity. And he says obesity isn't rocket science, it's more complicated. And that's very true. So obesity is a dysfunction of the coordination of these organs that result in problems in energy balance and homeostasis. So let's circle back to, actually, I'm going to tell you a story because I think stories are fun. Carrie and I want to say 2 years ago, we were doing our primary care psychiatry certification, and we were in San Diego in a lecture hall being spoken to by an extraordinarily prominent researcher and clinician who does depression. That's kind of his thing. And there's a couple hundred doctors in the room. This guy's up there talking, and he says, okay, somebody tell me what part of the brain is responsible for depression. And I remember looking around, brains are responsible for depression. Everybody's kind of mumbling, right? And he stops for a second, he looks at us and he goes, we don't know. And so that struck me. And I want to contrast that with this, because it turns out we know exactly what part of the brain is involved in energy balance. As a matter of fact, not only do we know where it is, it's in the lateral hypothalamus, we actually know the pathways, the neurons, the hormones, all of the factors really that are involved in these complex processes. It's very well defined. So the question is, okay, what's going on in that part of the brain? The lateral hypothalamus, that is part of the forebrain. It's sitting just above the brain stem. It is a very primitive part of our brain. So there's 4 other hormones that are sitting there along with these 2 pathways of hunger. And those, not to give you a bunch of long words, but those 4 hormones, melanocyte secreting hormone, growth hormone, gonadotropin releasing hormone, thyrotropin releasing hormone. What are those names about? Well, it turns out, actually, let me tell you this. If you know a woman of childbearing age, I want you to call them tonight, tell them to concentrate super hard and ovulate. Sounds stupid, right? It is stupid. We can't do it, right? Well, guess what? Those pathways, right, are right in the same exact center, a primitive function of our brain that is responsible for our energy pathways. So we can no more control our hunger than we control our height, when we're going to ovulate, how much testosterone we're going to be, the color of our skin, and how tall we're going to be, right? And how our thyroid hormone works, like how our thyroid works. Like, so it's ridiculous. Now, we can control hunger to some extent in the same way I can hold my breath, right? I can hold my breath, but not for very long, right? So hunger is a primitive function. It is a primitive reflex. Yeah, it's, hold on one sec. I'm having a technical problem. There we go. Okay, so it's a primitive reflex. So more myths. It's easier to lose. It's easier to keep the weight off than it is, or easier to whatever it says up there. And calories in equals calories out. Now that's technically true. It's not a myth, but it's an oversimplification that's actually pretty insulting, because whenever anyone says that, they don't understand it. We're going to talk about why that should insult people when they hear it. But what is the primary pathology of obesity? The primary pathology is that our body defends our weight. So whatever weight you get to, your body's going to want to keep it. And the question is why? Well, we've been Homo sapiens, some people say 150,000 years for us to think the way we think now. So other people say 300,000 years when we first became Homo sapiens based on our anthropologic features. Since that time, with the exception of maybe the last 75 to 100 years, we have not known as a species when or what or whether we were going to eat. So food has not been plentiful until recently. I mean, if you look in terms of a timetable, 75 years is nothing, right? So our body defends every ounce of weight. So if you're 100 pounds, 300 pounds, 500 pounds overweight, and you start to lose weight, your body's going to defend it with biologic processes. That's why obesity is a disease. That's why it has nothing to do with willpower. Another example of a biologic defense of weight, and I'm going to get into the 4 things it does in just a minute, but a biologic example is, I don't know if anyone's diabetic, but you can walk around with high blood sugar for months without ever knowing it. But the minute your blood sugar drops below a normal level, you feel it in a second, right? Another example of how we tolerate weight, right? Our body likes it, quite frankly, whether it's good or bad, right? Because of our history, right? Our $300,000 history on Earth, where we didn't know whether we'd eat. So that's why it's a problem. Now, the 4 things it does, remember I told you there's 4 biologic things that happen when we start to lose weight, no matter where we're starting from. The first is hunger. Remember we talked about it. That's a forebrain thing. That's got nothing to do with how we think. It's a primitive function. The other thing it does, our body's metabolic rate is lower the minute we start losing weight. And our metabolic rate accounts for about 70% of our energy expenditure. So you can imagine if that gets low, we burn less calories in a day the moment we start losing weight. And bodies are amazing. Our muscles become more efficient. So we can do the exact same task, physical task, but we're going to burn less calories doing it when we're losing weight. And this is the real kicker. Extract more calories from food. That's called an energy harvest. So here you are at one weight. Here you are 50 pounds lighter, you eat the exact same food in the same quantity, and you're going to pull more calories out of that food when you're 50 pounds lighter than when you were 50 pounds heavier. This is why it is not a willpower problem, right? These are biologic functions that we have zero control over. I put the Greatest Loser study out there. A lot of these slides are from medical residency lectures. So I put this in, but the point of the Greatest Loser lecture is if you remember this show where people lost all this weight, they took these people about 8 years after and they studied them in the NIH for about 2 weeks and did a lot of really amazing chemical and biochemical studies. And it turns out that that metabolic rate that fell, even years later, was still lower than it should have been based on their height, sex, weight, and muscle mass. So again, this is biology, right? This is not will. So, and when people say calories in versus calories out, well, that's technically true. It's insulting because what's happening is that caloric intake that you need to maintain your weight or to lose weight is progressively lowering over time. The more weight you lose, the less calories you burn, you make, right? The less you have to eat. So that's why people have a hard time losing and maintaining weight loss. So again, it is very hard to keep weight off. I bring this up because there's just a terrible stigma in our culture about weight and bullying and social media, and we have to try and ignore it, right? And I bring this picture up because I found it particularly egregious. So this is something that's supposed to be helpful, right? It's a girl, a young girl, and it says, warning, it's hard to be a little girl if you're not. Well, let me just say she is a little girl. You don't see young kids with cystic fibrosis saying stuff like that, right? Like, this is wrong, right? We have to understand that we need to fight the disease and not the people who have it. So that being said, let's get to a little bit more levity here and talk about medications we use to treat weight loss, which is probably why a lot of people are here. And what are you getting about med spas? We're going to, when you go to a med spa, we're going to talk about that. But it turns out there's a lot of medications we can use to treat weight. The vast majority of them work by suppressing appetite. And semaglutide and tirzepatide are no exception. Those are the bottom two. You can see those pretty amazing percentage of total body weight loss there. And so let's head right into that. So these are what are called the GLP family, and GLP stands for glucagon-like polypeptide or peptide 1. And so GLP-1s are a hormone made in the gut that work on receptors throughout the body. That hormone gets released when we're full. And so, you know, these amazing scientists have mimicked these hormones that we produce in our gut. And that's where these two medications come from. So semaglutide is the older one. When it is used for diabetes, it's called Ozempic. The exact same medicine when it's used for weight loss is called Wegovy. Tirzepatide is the newer twin. It is a GLP-1 receptor agonist, and it also works and mimics another hormone as well. We call it a twin cretin. That hormone is GIP, or gastric inhibitory peptide. It works at that receptor as well. That is called Zepbound when it's used for weight, and it is called Mounjaro when it is used for diabetes. So where do these medications work? Well, actually, they work all over the body, but the main way they work is food intake, decreasing food and water intake in the brain. So the main effect of these medications is in the brain. They also slow stomach emptying and the transit time through the gut, and they increase insulin secretion and diminish glucagon secretion. But there are really broader effects. These receptors for GIP and GLP-1s are throughout the body. They're, you know, muscle, they're in our vessels, they're in the fat pad around our heart, kind of all over the place. So besides the brain, the pancreas, and the stomach. So interestingly, this is the qualification as defined both by the OMA and by insurance companies. So a body mass index needs to be greater than 30 or greater than 27 with at least one complicating factor. And I've listed a few there. How effective are they? There's a lot of numbers, but it basically is going to point out that they're really effective, to be honest. Wegovy, 86% lost at least 5% of their total body weight. 32% lost 20% of their total body weight. And if you look at tirzepatide, the numbers are even higher. The tirzepatide numbers are looking at the dosage. So you'll see that to lose more than 20% of your weight, 30% of the people in the study did it at 5 milligrams. And those who were at 15 milligrams, the top dosage, almost 60% of the people at that top dosage lost more than 20% of the body weight. Now, look at the bottom thing. Nothing is perfect, right? 8% are non-responders, okay? This is just another slide showing the amount of weight loss that we're seeing measured over 40 weeks between Ozempic, which is semaglutide, and Mounjaro, which is tirzepatide, and side effects. So nothing is perfect, right? The side effects are similar for both medications. You'll see a black box warning on these meds, and it'll talk about thyroid cancer. So in rats, these two medications are associated with the development of thyroid cancer, very specific type in rats. So if you've ever had a specific type of thyroid cancer, you cannot take this medication. It's not really seen in humans to date to any great extent. Pancreatitis, however, is to the tune of about 1 in 1,000. Okay. In general, there have been almost no deaths. You stop taking the medicine, the pancreatitis goes away. But there have been a few reported deaths now in most people who've had more illnesses, associated complications. So it's not totally benign, but the death rate is probably somewhere around 1 in 20 to 1 in 50,000, right? Or maybe even less. But in general, still great medications. Now, acute kidney injury. Some of these meds cause vomiting. Both of them can. If you vomit for more than 6 or 8 hours and you don't get fluids, you can hurt your kidneys. Totally preventable. Any weight loss can cause gallstones. In diabetic patients, it can worsen the retinopathy. or gastroparesis, the coordination of the stomach as it moves food through the stomach and intestine. And there were early reports of depression that's been questioned. That being said, commonly, so those are rare side effects, quite frankly. Nausea, vomiting, constipation, diarrhea, burping, and reflux, common. And then, of course, the one that gets a lot of fame here is Ozempic face. What is that about? That's because, unfortunately, for us women, when we lose weight, we lose it in our face. And so if we lose it, all that, the fat is good in the face, it doesn't give us wrinkles, right? When you lose it, especially if you lose it quickly, you can have that appearance, right? And so a lot of plastic surgeons have done well with these meds. So who shouldn't use GLPs? There it is. It's a short list, actually. If you're allergic to it, if you have medullary thyroid carcinoma, if you have a very special type of endocrine cancer called MEN2, and if you're pregnant or you're thinking about getting pregnant. So generally really safe. And I will say for Wegovy, semaglutide, by the way, these medications are going to be the most prescribed medications of all time, without a doubt. And it's not just weight loss. Wegovy has been shown to decrease the incidence of major adverse cardiac events, so stroke and heart attack in people who have coronary disease. And it has been shown to decrease all-cause mortality. That's massive. The only other drug that's been shown to do that are the statins, right? So there's a lot of benefit to these medications. Zepbound has been shown to decrease the signs and symptoms and the parameters of sleep apnea. They're both being studied for the treatment of alcoholism and addiction. Why? Because those addiction centers, guess where they're sitting? Right in the hypothalamus, right? But in any case, I just wanted to mention about depression and suicide. The newest studies are saying these drugs probably make you feel better and not worse. Still needs some data, but there you go. Now, important point. So are GLPs a panacea? Will they do everything you've ever wanted and more, especially in terms of weight? The answer is no. This is looking at almost a year of weight loss, and then they're staying on the meds and they're following them in the next year. It's actually 68 weeks and 52 weeks, and you see there's weight gain, right? So how do we not have that weight gain? And the only way we keep our weight off is we have to address the other parts of health, which is where we come in because we address the other parts of health, right? It can't just be a pill. It needs more. You must exercise, right? You must change your nutrition if your nutrition isn't good. You must sleep better. When we don't sleep, our cortisol rises. When our cortisol rises, that is an obesogenic hormone, right? It makes us sick, right? Spikes. I love this. Carrie is our scientist, okay? She will try or do anything of the three of us in this practice. So right now she's wearing a continuous glucose monitor just because, right? She is interested in what is happening with my blood sugar at any given moment. But she was saying, like, I don't like talking in front of people, even though she's great at it. But so stress makes her blood sugar go up, and it does. It does. And actually, if more people could wear things like that, it'd be really cool, because what it does is it connects you to the idea that how we live, right? How we eat, how we sleep, how we go about our day has immediate physical effects, right? And long-term physical effects. So that being said, all important, let me just give a little thing on compounding pharmacy safe. So you can see, like, if you go, the cost of tirzepatide and semaglutide without any insurance or without any coupon is $1,300 a month. If you take the manufacturer's coupon, it's about $650. If you have insurance coverage, you might be able to get it to $0.25 or $50 a month. Now, if you don't have insurance coverage, you're going to look up tirzepatide on Google, and it's going to say, come get a shot, $239 a month, $299 a month. Those are compounded medications. So what are those? Because these meds are on a shortage, the FDA put out a statement saying they're a shortage, which allows pharmacies to compound meds. So they get similar molecules, they mix it, and then they sell it, right? Here's the problem with compounded meds. The FDA has put out a very strict warning. These meds are the salt-based forms they are not the studied molecules, right? They're not the studied molecules. They've not been shown to be safe or effective. They're often sourced in a non-regulated fashion, often overseas, and then they're compounded in pharmacies without oversight, right? The FDA has no involvement in protecting us with these compounded meds, and there's been numerous adverse event reports related to the use of compounded GLPs. So ultimately, and here's the technical message by the FDA, but ultimately, don't do it. That's basically what it says. We don't sell them. We get lots of sales materials saying, come sell our meds. No. Anyway, if you get the slides, which we all have access to, there's just a resource to help deal with online pharmacies to make sure what you're getting is the real deal. Because in addition to compounded meds, there are pharmacies that are selling fakes. Okay. That being said, I remember we said the whole lifestyle. Dr. Taquani is here to talk about the rest of it.
The rest of it.
All of it,
You guys
right.
all know now I don't like speaking in front of crowds, but I love the questions. The questions at the end will be fantastic. But yeah, my part of it is just addressing all the other things apart from just medication. So when we think about managing weight, we really need to think about it as truly in a comprehensive fashion. And according to the Obesity Medicine Association, any unique treatment plan is going to incorporate in the following pillars, with medical interventions being both medications and bariatric surgery, if that's an option for the patient. So we'll just touch on these one at a time. I mean, it could be several lectures, but I'd like to just talk about them one at a time. So nutrition, kind of as we learned earlier, there's more to the story than just the calories in and calories out. However, obtaining a calorie deficit is in and of itself what will lead to weight loss. And one important tool to help people achieve that deficit is the medications. So on average, we need to see about 500 to 750 calories deficit daily in order to see weight loss. But the actual food itself that we put in our body matters immensely as well. For example, we can all recognize that 1,200 calories of Mountain Dew and cookies is very different than 1,200 calories of protein and veggies. So what happens with the ultra-processed food and the carbohydrates is that it spikes insulin and it's digested very quickly, while protein and vegetables lead to this chemical signaling of fullness, and sometimes you're not even extracting all of the calories out of that food. And then additionally, as we lose weight, we're going to naturally lose some of our muscle mass as well. And our muscle mass is what determines our metabolic rate. It's responsible for our metabolism. So the goal for us, when we're seeing our patients is to preserve as much of that muscle mass as possible. And that's really done through a combination of protein intake and resistance training. So anytime our patients are losing weight, those are probably the number one and number two things we're focusing on with our patients. A question we often get is what diet is the best? And the good news to that question is that there really is no one best diet. So the best diet is one that's going to be a long-term sustainable solution for that individual patient. So this was kind of a nice study done in JAMA that showed the difference in weight change by diet type. It was comparing Atkins, which is essentially a ketogenic diet, so very high in fat, moderate protein, and very low in carbohydrates, to the Zone diet, which is an anti-inflammatory, low glycemic index diet, to Weight Watchers, which is a very low calorie, low fat diet, and finally Ornish, which is a plant-based diet. And on the left there, you can see there was no real difference in terms of weight loss when you compared the 4 different diets. But on the right, you can see there was a big change based on the dietary adherence for all 4 of these diets. So the more likely you are to adhere to a diet is the type of diet you should stick with. And if something's not a sustainable life change for you, such as keto might not be a good fit for every patient. If you can't see yourself doing that in another 20 or 30 years, then that's not a good long-term sustainable option for you. There are certain diets that are a little bit better in certain populations. So people that struggle with insulin resistance, so prediabetes or diabetes, might do better with a lower carbohydrate diet. And then the Mediterranean diet actually has a lot of benefit in terms of heart health, cancer prevention, and Alzheimer's. So now what about the gut and how does it affect our nutrition, and how does our nutrition affect our gut? So we've all experienced the fact that eating different foods can have an effect on our digestion. So our gut microbiome is a very complex and probably underappreciated contributor to weight and energy balance. It consists of trillions of organisms that are living inside of your intestines, and it plays a role in all sorts of things, including your immune system, inflammation, vitamins, mood, and even some of our endocrine functions. And the bottom line is that we want to keep our microbiome happy. So how do you do this basically? How do you keep your microbiome happy? It's basically through things like increasing the fiber in your diet, resistant starches, and less processed foods. So the foods like the ultra-processed carbohydrates are almost entirely absorbed in our early gut, leaving no food for that microbiome when you get a little bit further down. And I'm sorry, skipped ahead there. So this really interesting study here, published in JAMA in 2023, showed just that. Essentially, subjects were fed a microbiome-enhanced diet versus a typical Western diet. And then they determined the energy expenditure in these different categories. So on the top left, you'll see that there was actually more energy lost in bowel movements of patients on the microbiome-enhanced diet. And on the top right, you'll see that in the typical Western diet, almost all of that energy was metabolized, 95% versus 89%. And there were even some participants that only metabolized 85% of their energy in that microbiome enhanced diet. And then the final graph at the bottom shows what that equates to in terms of calories. So you can see like almost 120 calorie difference if you're eating a typical Western diet versus a microbiome enhanced diet. So moving on a little bit to the next pillar of exercise. Exercise is so important to all of us, irrespective of weight. So I almost like to look at it separately and independently of weight. This is the physical activity guidelines for all Americans that tell us to move more and sit less, and that some activity, no matter what the activity is better than no activity. All adults should be doing about 150 to 300 minutes of moderate intensity activity. And say you're a person that's busy or working and you don't have that 150 minutes, you can get by with 75 minutes if you're doing a more vigorous intensity, such as an aerobic activity. It should be spread throughout the week. And then if you're a person going over that 300 minutes per week, you get additional health benefits. In addition to that, people should be doing muscle strengthening activities of moderate or greater intensity that involve all major muscle groups at least 2 days a week. And that's to preserve your function as you're getting older, the ability to lift things, lift over your head. So these are just guidelines for all Americans. If you've never heard of exercise intensity, just kind of take a look at this chart. So if you're thinking about your 150 minutes a week, you want to be aiming for like a 5 or a 6 on that chart. So that's basically, think of it as like walking as if you're late to a meeting. So a nice brisk walk for 30 minutes, 5 days a week. And when you get into the vigorous activity, it's going to be more like a 7 or 8 on that chart. So you're really kind of huffing and puffing, not able to hold a conversation. And then benefits of exercise, like I said, it's important for all of us. It decreases our all-cause mortality. It decreases all sorts of different health diseases like coronary heart disease, stroke, cancer, diabetes, obesity, hypertension, osteoporosis. And then there's a decrease in the risk factors for diseases such as overweight or obesity, hypertension, and high cholesterol. It's good for our brain health, our cognition, our mood. It's releasing endorphins, so it makes people feel better after exercise. And then as we continue to age, it decreases our risk of falls or injuries from falls. So very healthy. The good part about exercise when it comes to weight loss, if you're not yet a person who's exercising, is that it actually is not as important in the weight loss stage as it is in the weight maintenance stage. In the weight loss stage, a lot of it has to do with diet and changing some behavioral habits, but it does become very important in terms of weight maintenance. So there's a very nice national weight control registry, which is people who've lost 30 pounds and kept it off for a year or more, and 94% of these people report that they've increased their physical activity. 90% of them are exercising about 60 minutes a day, 5 days a week. And then walking is the most popular form of exercise out there for most people. It's something you can do, even in Chicago, in the mall, in the winter. So definitely a very common form of exercise. So moving on to behavioral modification, this could be a whole lecture in and of itself. Definitely understand that behavior change is hard. So studies have shown that over 40% of our day is dictated by habits, and habits can be really difficult to change. So sometimes I recommend that even just understanding the why behind why you want to lose weight can make people more successful. And setting your why behind something that's really deeply meaningful to you. So if it's that you want to be around for the grandkids, or to keep up with them later in life, or you want to reverse your prediabetes, or you want to just feel more comfortable and have less joint pain, the more important that why is to you, the more successful you're going to be in terms of weight loss. And then when it comes to weight loss, you definitely want to find a provider that understands how deeply ingrained our relationship with food can be. Emotional eating is very common. It's extremely common. I see it every single day in almost all of the patients I treat. Food is part of our culture. We eat when we're happy, we eat when we're sad, we eat when we're bored, lots of different reasons. But we want to be working more towards a neutral relationship with food. So seeing it more just as fuel rather than something to turn to in those emotional situations. So whenever someone's working on kind of developing new habits and setting goals, I always recommend using the SMART goals. I'm sure some of you in here have heard of those before. It's really common in like the education world. But goals that are specific and measurable, attainable, relevant, getting back to that why, and also timely. So giving yourself kind of a time frame in which you want to achieve a particular goal. And finally, if you've never attempted to make kind of some behavioral change around food, I always suggest starting with mindful eating. It's a really nice, easy place where you can start. It involves just paying attention to your body's hunger cues and your emotional and physical kind of responses to food, trying to eliminate distractions like eating at the TV or eating while working on your computer, having a dedicated eating place, and then actually social interactions. They found that eating with other people tends to slow down people's eating. So having other folks around while you're eating, and then just focusing on the food. So putting it in a separate container instead of a bag, put it in a bowl, putting your spoon down and just enjoying all the bites of food. And finally, keeping those trigger foods that you know are going to be temptations out of sight, maybe throwing the chips on the highest cabinet in the pantry, and then making more accessible and healthy foods that are like right there. You open your refrigerator door and you have all sorts of cut up vegetables ready, to eat. So just some really easy things. This is a book you can purchase on Amazon on mindful eating. That's kind of an interesting place to start. I can't read it right now, but
UST?
I can get it for you later.
That looks like the Andrews.
No, it's because it's registered dietitian. Vincent, TSUI.
Yeah, TSUI, VINCCI TSUI. Sorry, this thing is way smaller than that. And then finally, if you're at a place where you're looking to lose weight and get healthier, don't forget about these healthy habits. Dr. Schwab had mentioned it before, but stress reduction, that cortisol bumps up, you're in a state of stress, it's going to make you more prone to eating. So things you can do for stress reduction, whatever works for you, that's going to be a very individualized thing for each person, mindfulness, yoga, meditation. There's a lot of data behind getting outside around trees. Like trees are relaxing to a lot of people. Getting high quality sleep, so recommending like 7 to 9 hours. If you don't get that amount of sleep, your hunger and your cravings and your sensation of fullness are definitely going to be affected. And that's where sleep apnea, even whether or not it's diagnosed or undiagnosed, can play a role in why people are having trouble losing weight. Smoking cessation, we hear a lot about that, but also alcohol, I find, is a really easy way for people to start changing some habits and seeing some weight loss. It tends to bring along friends, meaning it'll oftentimes bring more alcohol as well as the snacks along with it. And then finally, just looking for any underlying medical problems, such as depression or anxiety, ADHD. Some people struggle with binge eating. Those can all be contributors to why you're having a difficult time losing weight. And then I like to tell my patients, whatever you do to lose weight, you have to keep doing. Dr. Schwab did put this graph up there before, so it makes a lot of logical sense, right? Like if you were doing keto and you lost 30 pounds and you stopped doing keto, you're likely going to regain the weight. Same thing for Weight Watchers, unless this is something that you can continue. And that's why these medications are indicated for long-term use if necessary to regulate your biology and just keep you in a state where you're feeling comfortable and full and satisfied with smaller portions and not feeling hungry all the time. So yeah, whatever you do, whether or not that's exercise, medication, lifestyle changes, you need to be able to keep that going to see continued weight maintenance. So in conclusion, just even if we have excess weight, we need to be comfortable with ourselves, love ourselves. If you or someone you know struggles with excess weight, understand that this is a chronic disease state and be supportive. And we can want to fix that problem and prevent any future medical problems, but not see ourselves as the problem. So I think we have a couple minutes, so I think we did pretty good getting through it in case you guys had questions, which usually people do have questions at the end.
I got a question.
Yeah.
One of the challenges for those of us who have Medicare for this kind of work.
That is a very legitimate challenge. So Medicare, I suspect that in the next few years, there's going to be quite a few changes coming with Medicare. So Medicare just did approve Wegovy for a cardiovascular indication in people who struggle with obesity and overweight. Because of that, it's a 20% risk reduction in terms of preventing another heart attack, stroke, or peripheral artery disease. So the fact that they approved that makes me, I guess, think that in the future there will be some more coverage for the GLP medications. In the meantime, though, cost barrier is a pretty true thing. Eli Lilly did just come out with if you have Medicare or Medicaid, a direct-to-patient program where they've eliminated the middleman, meaning the insurance company, and they're offering it at a lower price rather than $1,300, $400 to $500 for the medication, which is still expensive. And then the other thing to think about is sometimes there are other medications that are not just the GLP medications that people can do great with. So if you don't have any reason, not to be taking some of these older generic medications, you might be eligible for them. And oftentimes we can break them into two different generics. So Qsymia is a good example. That's a combination of oral phentermine and oral topiramate, where the combination pill is $100, but you can break it into two different generics and get it to a more reasonable cost.
Office visits too, like the coverage of the doctors.
Oh, the doctor's visits are covered. Yeah. Doctor's visits are not the issue. It's more the medication that we run into. And we do a lot of appeals in our work, like fighting to advocate for our patients on their behalf of the medications that we know are truly going to be the most useful medications. So we do everything in our power to help assist our patients, but part of it just comes down to the insurance coverage.
How high you can go on as Ozempic? How many milligrams?
2.4.
2.1.
Ozempic is 2, and then Wegovy is 2.4.
Oh, yeah, right. So Wegovy is 2.4, Ozempic is 2, yeah. But 2.4 is the 1.7 and 2.4 are the weight loss doses. Those are the study doses.
And I haven't been out that long to say, so do some people, would we need them for a lifetime possibly?
Potentially.
Potentially, possibly. I mean, they haven't really been out long enough to know that.
And
but-
some of them, so liraglutide is an older one, that's Saxenda Victoza. That one's been around for 20 years, so that's why I feel pretty comfortable with the safety of the medications. We're not seeing thyroid cancer in the 20 years that liraglutide has been out. Ozempic's been out for about 10 years. And then Wegovy, is that founder a little newer to the market. But again, I have seen patients come off of them, but those are patients who have made these 180 lifestyle changes, going from eating, all sorts of unhealthy things and not exercising 1 minute to actually my half brother is being treated. So he went from that category to exercising every day and only eating, protein and veggies. And he's been able to come off the medication and maintain his weight loss and do okay. But that was a pretty drastic lifestyle change. When it comes down to some of this is just inherently your biology. And if you come off of it, some of those hunger cues will start coming back. So that's where we just kind of have to accept that this is and what I tell my patients is if this is we're looking at as a chronic disease, we wouldn't tell somebody who has high blood pressure, who's well maintained on the blood pressure medication, well, you're good now, let's just stop the blood pressure medication and see how you do. We have to accept that this is, and part of that's the stigma in society. We have to accept that some people's bodies are just different. And if this truly is a chronic disease, then if it's a tool that helps you to maintain, a healthy lifestyle and prevent future medical problems, then it's okay.
What are the impacts on things like phentermine and Wegovy on the heart? I asked myself since I was on phentermine for a bit, and I was having some success, but then I had to switch providers due to insurance, and my new provider did not want me to stay on that because of a previous heart condition, even though my EKG was normal at the time. do they have adverse effects to the cardiovascular system, these type of medications, or can they be safe sometimes?
Oh, not only can they be safe, they're actually
Would help.
designed for, right? Like, so, yeah, so actually it helped, right? You know, I think the phentermine question in someone who has underlying coronary artery disease is a very individual decision. And certainly, coronary artery disease and hypertension with phentermine alone can certainly make those worse. So that has to be a risk-benefit discussion. Qsimia, which is a combination of phentermine and topiramate that Dr. Taquani was talking about earlier, that does not increase blood pressure, right? It can increase heart rate, but so it really depends. And, you know, if we could prescribe everyone the GLPs like semaglutide in your case, then we sure would, right? Like, because it makes sense. But we have to wait for the insurance companies to catch up. And actually, I want to just clarify that it's not the insurance company. Right now, your employer gets to choose whether or not to cover medications for weight loss. The insurance company is just they're not making the decision, they're just carrying it out. Okay, that makes no sense. Like, since when do employers get to decide whether to treat hypertension or diabetes? They shouldn't, right? Yeah. Or cancer, right? Exactly. So that's really this. So with all this science, right? Like, there's been a shift really in the idea of what obesity is and why weight is a problem, right? We just went through that, and that is what's changing the discussion. And hopefully the politics will follow. I think so. I mean, I think Medicare is the first one. Approving Wegovy for coronary artery disease, big deal. But it's still not formulary, so even if you have Medicare and you get prescribed it and they cover it, what was the cost for?
It depends on your Medicare plan. It's just
Yeah.
all over the
But
books.
it's
I've got one
hundreds.
Medicare patient who paid $1,000 and another who pays 25. So it's nothing standardized yet.
Right, it's
Um,
crazy. Yeah.
But getting back to your question about phentermine long-term, and Qsimia is a combination medication that's been approved for long-term use in patients. Phentermine was initially prescribed by the FDA, I think back in 1959. It was approved for 3 months of use, which is why some physicians are nervous about giving it for longer than 3 months. But the reason it's not been gone back to, and circled back to, is it's cheap and it's generic, and there's no reason that people are going to invest money in studying it at this point. But multiple national societies, including the Endocrine Society and the Obesity Medicine Association, have said it's okay to use for long-term use.
And would prescribe it for long-term use. Yeah.
Good discussion, guys.
So if somebody did want to be on a medication like phentermine for weight management because of those reasons, that it's more often covered by insurance because it's been around and it's cheap and it's effective. But that 3-month barrier, that was a barrier for me actually, that they cut it off and then I had to get reauthorization and it was difficult. How does one have those conversations with their healthcare provider to try to be on medications like that? Or like the other one you mentioned, that Qsimia?
Well, let me just, phentermine now, the generic phentermine is less, with a good RX coupon, is less than $20 a month. So you don't need you can just pay out of pocket. You don't need a prior auth anymore for phentermine. So the generics are definitely available, but I mean, you'd bring it up and it would come to your physician's comfort level with respect to any underlying disease, right? Because we don't want to do harm, right? Yeah. But yeah, it's cheap. You don't need a prior auth for phentermine. Out-of-pocket cost is less than a copay most of the time.
And they've actually shown with high blood pressure that phentermine, you can actually decrease your blood pressure if you lose weight. So weight loss in and of itself, will help you to control your blood pressure. So
that'd be something you'd want to be on a home blood pressure monitor, and you want to take your blood pressure frequently. I mean, that's a involved conversation and an involved risk-benefit discussion. But of course, phentermine and topiramate doesn't raise blood pressure. Interesting.
well, thank you guys for coming tonight. It was really nice.
Thank you.
Understand it works very well.
I was gonna say, that's right.
I started with Dr. Schwab in